Usually, when you talk about a medical diagnosis, there is an expectation of precision.
Right. People want a clear answer.
Exactly. If you are, say, a medical student or a junior doctor listening to this deep dive right now, you know the comfort of that precision. A patient comes in with a broken arm, the x-ray shows a jagged white line through the radius, and you just point to it and say, there is the problem.
Yeah, it is entirely binary, broken or not broken.
Right. It is a clean, isolated event,
Yeah.
but that whole framework kind of falls apart when you zoom out, doesn't it?
Oh, it completely falls apart. I mean, that reductionist view works incredibly well for acute trauma in a high-resource setting. We really like our medicine to be visible, neatly categorized and fixable with just a single intervention.
Which is basically the opposite of global public health.
Exactly. Especially when you step into the world of child health. The diagnostic landscape gets incredibly murky.
Because you aren't just looking at the biological pathogen anymore.
Right. If a child in a low-income setting presents with a severe cough, you aren't just looking at the Streptococcus pneumonia bacteria in their lungs. You have to look at, the smoke from the biomass cooking stove in their home.
Oh, yeah. And the socioeconomic factors too, right?
Exactly. You are looking at their mother's education level. You are looking at a regional supply chain that has been, out of amoxicillin for 3 weeks.
So to navigate that kind of complexity, you really have to fundamentally shift your perspective.
You do. You have to stop viewing child health as a series of isolated clinical brush fires, like a fever today, diarrhea next month, and you have to start looking at it as a massive, complex architectural project.
I love that. I really want to run with that architectural metaphor today because I think it perfectly frames our mission for this deep dive.
It really does.
So imagine you're building a house. The childhood years, and specifically the very early years, they are the pouring of the foundation and the erecting of the load-bearing walls.
Right. The absolute critical starting phase.
Exactly. That foundational structure has to support this building for the next 70, 80, maybe 90 years of the human life course.
And if you use substandard materials, or say, if a storm hits while the concrete is still wet, the structural integrity of that entire building is just permanently compromised.
Yeah. It really doesn't matter how beautiful the roof is decades later. I mean, the house is fundamentally weak.
So taking that metaphor further, public health acts as the civil engineering, right?
Yeah.
It's the zoning laws and the maintenance systems designed to protect that foundation while it cures.
Which perfectly sets up what we are doing here today. We are serving as your active companion to Chapter 10.3 of the Oxford Textbook of Global Public Health, focusing entirely on child health.
Yes, and if you are reading along with us, our goal is to really help you synthesize the clinical mechanisms of childhood diseases with the epidemiology of, how they spread.
And how we actually engineer health systems to fight them. We want to give you those memory anchors to carry into your clinical practice or your public health exams.
To start, we really need to define our terms based on the textbook's strict epidemiological life course timeline.
Right, so we are focusing on the under 5 bracket. But this isn't just some arbitrary age grouping, is it?
No, not at all. It is divided into 3 distinct construction phases, basically. Each has its own unique structural vulnerabilities. First, you have the neonatal period, which is defined strictly as the first 28 days of life.
Just 28 days. But they are so critical.
The most precarious phase of the entire human life course, actually. The infant is transitioning from this highly regulated placental life support system to autonomous physiological function.
Right, they suddenly have to do everything themselves.
Exactly. They have to regulate their own temperature, oxygenate their own blood, and face this massive barrage of environmental pathogens with an incredibly naive immune system.
And then following that 28-day window, we enter the infancy period.
Right, which covers the remainder of the first year of life.
So that's month 2 through month 12.
Correct. And finally, we hit the preschool years, which spans from age 1 up to the 5th birthday.
So why do epidemiologists chop it up this way?
We divide them this way because the epidemiological hazards shift dramatically across these phases. I mean, a pathogen that is just a mild nuisance to a 3-year-old can be rapidly fatal to a 3-day-old.
That makes total sense. So let's look at the sheer scale of those hazards by diving into the mortality data.
The numbers are pretty intense.
They really are. The chapter references data from around 2012 and 2013, and honestly, the raw numbers are difficult to process. We see roughly 139 million births globally each year.
Wow.
Yeah, but of those, 6.6 million children will die before they reach their 5th birthday.
To really contextualize that 6.6 million figure, you kind of have to compare it to other global health priorities.
Like what?
Well, we dedicate massive international resources, right? Billions of dollars and endless research to combating HIV, malaria, and tuberculosis.
Right. The big three.
Yeah, but 6.6 million under 5 deaths a year is more than twice the number of individuals dying from HIV, malaria, and TB combined.
Wait, really? Twice as many?
Yes, it is a staggering contrast.
That is wild. Now, I should note that 6.6 million is actually a 36% decline from the year 2000, which proves public health interventions actually do work.
They absolutely work. But to drive that number down further, we need some serious pattern recognition.
Let's talk about the timing first.
So over 70% of those under 5 deaths happen within that first year of life. That's the neonatal and infancy periods we just defined.
So the risk of mortality is highest the closer you are to the actual moment of birth.
Exactly. Going back to our metaphor, the house is most likely to collapse the very day the concrete is poured.
Okay, so the temporal pattern is clear. But the geographic pattern is just as stark, right?
It is. These structural failures are not distributed evenly across the global neighborhood at all. Over 80% of all under 5 deaths cluster in just 2 regions, Sub-Saharan Africa and South Asia.
80%. And Sub-Saharan Africa alone only holds about 25% of the world's under 5 population.
Right.
But it accounts for 51% of the global under 5 deaths. Meanwhile, Europe accounts for less than 1%.
It is a massive disparity. And if you zoom in even further, 50% of all global under 5 deaths occur in just 5 countries.
Let me guess. High population countries.
Yep. India, Nigeria, the Democratic Republic of Congo, Pakistan, and China.
So understanding why the burden is concentrated there requires looking at a really foundational concept from the text, the epidemiological transition.
Yes, this is crucial. The epidemiological transition describes the dynamic shift in population morbidity and mortality as a society develops, economically, socially, and infrastructurally.
So in a lower income setting, what is driving the mortality?
The primary drivers are acute infectious diseases, things like pneumonia, diarrhea, measles, and severe nutritional deficiencies.
So sticking with our house metaphor, that's poor municipal zoning, a lack of clean water plumbing, and insufficient building materials.
That's a great way to put it. But as a country develops, say they bring in clean water, establish cold chains for widespread vaccine coverage, and secure the food supply, those acute infectious diseases just plummet.
Right. And as those acute infections decline, the relative proportion of other causes of death artificially inflates.
Exactly. The absolute number of deaths goes down, but the slice of the pie changes. The pattern shifts toward perinatal causes, like complications from premature birth or birth asphyxia.
And congenital anomalies or non-communicable diseases start taking up more of the chart.
Right. Just to give you a stat, between 2000 and 2010, the world saw 2.7 million fewer under 5 deaths. And 60% of that reduction came specifically from beating back pneumonia, measles, and diarrheal diseases.
Which brings us to a crucial differentiation for anyone studying public health. And that's the difference between hazard and risk.
Oh, this is so important to unpack.
The textbook points out that a child in a low-income country is nearly 14 times more likely to die before age 5 than a child in a high-income country.
14 times.
Yeah. Now, the biological hazard, let's say the rotavirus that causes severe diarrhea, is a constant. It exists in London and it exists in Lagos.
Right. The virus doesn't care about borders.
But the risk of that hazard resulting in death is astronomically different.
Because the biological pathogen is merely the match. We really have to analyze the structural kindling using the risk to exposure to outcome framework.
Let's trace that pathway. How do poverty and lack of maternal education act as multipliers of risk?
Well, let's say a mother lacks access to education. She may be less equipped to recognize the early clinical warning signs of respiratory distress, like fast breathing.
So that structural deficit increases the duration of the child's exposure to the pathogen before they even seek care.
Exactly. And if the family lives in deep poverty, they are likely using a biomass stove indoors. The constant inhalation of that particulate matter paralyzes the respiratory cilia, basically stripping away the child's mucosal defenses.
So the biological hazard now has a totally frictionless path to the lower airways.
Yeah. And finally, even if the family manages to reach a rural clinic, a broken health system might mean a complete stockout of basic antibiotics.
So that 14-fold disparity in mortality is entirely driven by those structural determinants.
Entirely. The rotavirus isn't 14 times more lethal in sub-Saharan Africa. Rather, the absence of clean water, intravenous fluids, and trained personnel guarantees that the resulting dehydration is 14 times more likely to be fatal.
Man, that is a heavy realization. And I think that transitions us naturally from mortality to morbidity, sickness.
Right, and measuring morbidity is notoriously difficult.
Yeah, the text notes that. I mean, a death is a discrete, measurable event that usually generates some form of official record. But a child suffering their fourth bout of pneumonia in a remote village.
They might never appear in any health surveillance database at all.
So the surveillance radar in low-resource settings is full of blind spots.
It is. However, the available data confirms that the primary drivers of morbidity closely mirror the primary causes of mortality. But the critical concept here is really understanding long-term sequelae.
I like to call this the cascade effect. In acute medicine, we often treat surviving an illness as a return to a 100% baseline, right? The patient didn't die, so they were basically cured.
But in global child health, surviving severe pneumonia leaves a permanent mark on the structural blueprints.
How common is that?
Well, the text cites an estimated 120 million episodes of pneumonia in under fives in 2010, with about 14 million of those progressing to severe illness.
That is a staggering amount of severe illness.
And this is where we have to look at the permanent structural damage. The data shows an overall 5.5% risk of long-term major respiratory sequelae in children who recover from pneumonia, even if they were never hospitalized.
Wait, 5.5% even without hospitalization?
Yes, and if they were severe enough to require hospitalization, that risk of permanent respiratory damage triples.
So we're talking about permanent issues like bronchiectasis, chronic airway hyperreactivity, and fibrotic scarring.
Exactly. So going back to the house, the load-bearing walls of the respiratory system are permanently weakened.
That child now enters the rest of their life course with diminished lung capacity, which makes them vastly more susceptible to future infections and eventually adult non-communicable lung diseases.
And we see that exact same systemic stress with diarrheal diseases.
Right. The text estimates a median of 2.9 episodes of diarrhea per child per year.
Which is huge. In sub-Saharan Africa and South Asia, that translates to over 400 million episodes annually per region.
400 million. But again, we can't just view diarrhea as an acute inconvenience of fluid loss, right?
No, not at all. It is a profound, recurring systemic trauma. Repeated enteric infections trigger this chronic inflammation of the gut lining. It's a condition often termed environmental enteropathy.
What actually happens in the gut during that?
Well, the intestinal villi, those microscopic fingers responsible for absorbing nutrients, they literally become blunted and flattened.
It's like the plumbing system of the house corroding over time.
That's perfect, yeah.
Because even if you pour high-quality water and nutrients into the pipes, the system just can't absorb or distribute them.
Precisely. So the child might actually be consuming adequate calories, but their compromised gastrointestinal mucosa simply cannot absorb the macronutrients and micronutrients.
And that repeated biological insult directly stunts their long-term somatic growth and cognitive development.
Which leads us directly into the third major indicator of under 5 health, which is nutrition, growth, and development.
Now, the terminology surrounding malnutrition is frequently blurred in mainstream reporting. You hear terms thrown around interchangeably, but the textbook defines 3 core indicators with strict academic precision.
And we really need to break down stunting, wasting, and underweight, starting with the actual mechanisms behind them.
Let's start with stunting.
Yeah.
How is that clinically defined?
Stunting is defined as a child falling below -2 standard deviations, or -2 z-scores, from the median height for age of the WHO child growth standards.
So the child is significantly shorter than their genetic potential dictates for their specific age.
Right. But the mechanism is what really matters for a public health intervention. Stunting is the physical manifestation of chronic, long-term deprivation.
To bring it back to the house construction, stunting basically means you have been receiving a trickle of substandard building materials over a period of years.
Yeah, exactly.
You are still building the house, but it will never reach the height on the original blueprints because the daily brick delivery is always short.
It is a biological adaptation to chronic scarcity, which is often compounded by those repeated infections we just discussed.
Okay, so that's stunting. What about wasting?
Wasting, on the other hand, is defined as falling below -2 standard deviations from the median weight for height. So this child is dangerously thin for how tall they are.
So wasting is an acute event. It's the hurricane suddenly ripping the roof off the house overnight.
Exactly right. It indicates a severe, immediate nutritional crisis. The body rapidly metabolizes its own muscle and fat reserves just to maintain basic internal organ function.
What usually triggers wasting?
It is typically triggered by a sudden disruption in food security, such as a famine or conflict, or by a severe acute illness, like a massive diarrheal infection that just strips away body mass in a matter of days.
Got it. And then we have the third term, underweight. This is defined as falling below -2 standard deviations from the median weight for age.
Right, and underweight is essentially a composite indicator. It tells you a child is too light for their age, but it lacks mechanistic specificity.
Meaning a child might be underweight because they are chronically stunted, or because they are acutely wasted, or maybe a combination of both.
Precisely. And if you are an epidemiologist designing an intervention, that differentiation is absolutely critical.
Right, because if your surveillance data shows a high prevalence of wasting, you need to deploy emergency therapeutic food and intravenous fluids immediately to stop the acute collapse.
But if the data shows high stunting, those emergency food drops won't solve the root problem. You need 10-year structural investments in agriculture, female education, and sanitation plumbing.
You must align the time scale of your intervention with the time scale of the physiological deprivation.
Beautifully said.
Now, the textbook also highlights a phenomenon that feels kind of counterintuitive when discussing global undernutrition, and that is the overweight paradox.
Oh, yes, this is a massive emerging issue.
Yearly 43 million under 5 children globally are now classified as overweight, which is a 54% increase since 1990. How does childhood obesity factor into the global public health landscape?
It is the epidemiological transition unfolding in real time. In many low and middle income countries, as economies transition, populations move from traditional diets to highly processed foods.
Foods that are dense in empty calories, sugars, and trans fats.
Exactly. But they are entirely devoid of essential micronutrients. So we frequently observe a dual burden of malnutrition, sometimes within the exact same community.
You mean stunting on one side of the street and childhood obesity on the other?
Exactly that.
And from a life course perspective, an overweight infant is laying a foundation that is severely predisposed to adult non-communicable diseases. Things like type 2 diabetes, hypertension, and cardiovascular disease.
Right. And whether we are discussing undernutrition or overnutrition, the impact is not limited to just somatic growth. It profoundly dictates neurological development.
This is arguably one of the most vital concepts in the text. The first 1,000 days of life, from conception through the second birthday, represent a window of maximum neuroplasticity.
Yes. The infant's brain is undergoing explosive synaptogenesis. It is quite literally wiring its electrical system based on environmental inputs.
So the foundation isn't just the physical framing of the house, it's the entire complex electrical grid.
To build that grid optimally, the brain requires adequate micronutrients like iron, iodine, and zinc.
And it requires protection from the systemic inflammation caused by repeated infections, right?
Exactly. And crucially, it requires psychosocial stimulation and responsive caregiving. Think about it. If a child is severely malnourished or chronically ill, they conserve energy by becoming lethargic.
Right. They don't play. They don't explore their environment.
And because they don't explore, they do not elicit the necessary social interactions from their caregivers.
And that deprivation permanently prunes their neural pathways. The text notes that annually, over 200 million children under 5 suffer significantly impaired cognitive and social development because of these exact early deficits.
So you aren't just looking at a shorter child, you are looking at a permanent reduction in human cognitive capital.
Which is a profound loss for a society.
It truly is.
So now that we have mapped out the architecture of the problem, mortality, morbidity, and nutrition, we need to examine the engineering solutions.
Let's shift to the interventions.
The second half of the chapter systematically addresses the health needs of the child in low and middle income countries, categorized by the major causes of mortality.
And we begin with the most vulnerable phase of all, newborn conditions.
The operative framework here is the continuum of care. Because if you view newborn care as an event that begins the moment the umbilical cord is cut, you have already missed the most critical intervention windows.
Right. The continuum must begin during pregnancy, stretch through the intrapartum period of childbirth, and continue into postnatal care.
This is that upstream engineering we talked about.
Exactly. During the antenatal period, public health interventions focus on fortifying the mother to protect the fetus.
What does that look like practically?
Well, it includes administering tetanus toxoid immunizations to prevent neonatal tetanus. It includes screening and treating for syphilis and HIV to prevent vertical transmission.
And providing intermittent preventative treatment for malaria.
Right. Yes, all of those are vital structural supports before the baby is even born.
The text provides a fascinating breakdown in Box 10.3.1, detailing the basic care required for every newborn at the moment of birth.
And it's probably not what people expect.
Right. When you study high-resource neonatology, you think of CPAP machines, surfactant administration, and complex digital incubators. But the global public health interventions listed here are profoundly low-tech.
They are very low-tech. We are talking about thoroughly drying the baby immediately, placing them in direct skin-to-skin contact with the mother, hygienic cord care, and the early initiation of breastfeeding.
But their physiological impact is massive. I mean, neonates have a very high surface area to mass ratio and minimal brown fat.
Which means they lose heat incredibly fast.
Right. So drying the amniotic fluid off the skin halts evaporative heat loss. And then skin-to-skin contact utilizes the mother's body as a natural thermoregulator.
Because hypothermia in a neonate quickly triggers a lethal cascade of hypoglycemia, hypoxia, and metabolic acidosis.
It's all connected. What about the cord care?
Hygienic cord care using chlorhexidine prevents the umbilical stump from becoming an entryway for sepsis and tetanus.
And early breastfeeding. That isn't just about calories, is it?
No, it is the delivery of colostrum. Colostrum is essentially the infant's first oral vaccine.
Oh, that's a great way to describe it.
It is packed with maternal IgA antibodies, macrophages, and lactoferrin, which immediately coat the infant's sterile gastrointestinal tract, providing a protective barrier against enteric pathogens.
Okay, so that covers routine basic care. But the text also dives into the management of complications, starting with preterm births, which claim nearly 1 million newborn lives annually.
A huge global burden.
Right. So if a mother goes into premature labor in a setting without an NICU, how does public health engineer a survival strategy?
Well, the most effective intervention happens before the baby is even delivered. If preterm labor is imminent, administering a simple, inexpensive course of corticosteroids to the mother accelerates the maturation of the fetal lungs.
Let's explain the mechanism there for the medical students listening. The primary reason premature babies die is respiratory distress syndrome.
Right. Their immature lungs lack type 2 pneumocytes, which are the cells that produce surfactant.
And surfactant is the soapy substance that reduces surface tension in the alveoli. It prevents the tiny air sacs from collapsing every time the baby exhales.
Exactly. So the maternal corticosteroids cross the placenta and chemically force the fetal lungs to rapidly synthesize surfactant,
which dramatically improves the newborn's ability to oxygenate its own blood upon delivery.
Yes. And post-delivery, if incubators are unavailable, we utilize kangaroo mother care,
which involves continuous 24/7 skin-to-skin contact between the low birth weight infant and the mother's chest.
And clinical trials consistently demonstrate that kangaroo mother care regulates the infant's heart rate, oxygen saturation, and temperature far more effectively than primitive artificial incubators.
While simultaneously promoting exclusive breastfeeding, it's a brilliant low-tech solution.
It really is.
The next major complication is birth asphyxia, when a baby fails to initiate and sustain breathing at birth. The text says this accounts for roughly 10% of all under 5 deaths.
Which is why the system's approach to asphyxia relies heavily on primary prevention during labor.
And this is achieved through the use of a partograph, right?
Yes, the partograph. It is a brilliant piece of visual data engineering used by birth attendants. It simply plots the progression of labor, specifically cervical dilation and fetal heart rate, against time on a graph.
It's basically the blueprint timeline for the birth. It features pre-calculated alert lines and action lines.
Exactly. Instead of relying on subjective guesses about whether labor is taking too long, the attendant plots the data points. If the line crosses the alert threshold, they know immediately that labor is obstructed or the fetus is in distress.
So they can intervene, perhaps initiating a transfer to a surgical facility for a cesarean section, hours before the baby becomes asphyxiated.
But if primary prevention fails and the baby is born apneic, meaning not breathing, you immediately move to secondary prevention, neonatal resuscitation.
Which means every single skilled birth attendant, globally, must be trained and equipped to provide positive pressure ventilation.
Using just a simple self-inflating bag and a mask perfectly sealed over the infant's nose and mouth, the attendant uses ambient room air to manually force oxygen into the lungs, kick-starting the central respiratory drive.
Moving forward on the life course timeline, we transition from the neonatal period into infancy and the preschool years.
And here we encounter the biggest infectious killer of children globally: acute respiratory infections, or ARIs, primarily pneumonia.
ARIs are responsible for 18% of all child deaths worldwide. That's massive.
It is. So the public health strategy for ARIs relies on a multi-layered defense. The outermost shield is widespread immunization.
Because the vast majority of severe bacterial pneumonias are caused by two specific pathogens: Streptococcus pneumonia and Haemophilus influenza type B, or Hib.
And the introduction of protein-conjugated vaccines for these pathogens has been completely revolutionary.
How exactly do those conjugate vaccines work?
Well, by linking the weak polysaccharide capsule of the bacteria to a strong carrier protein, these vaccines elicit a highly robust T-cell-dependent immune response even in very young infants.
So widespread deployment of pneumococcal conjugate vaccines, or PCVs, and hive vaccines not only provides direct mucosal immunity to the vaccinated child, but it also dramatically reduces the carriage of these bacteria in the nasopharynx across the entire community.
Generating vital herd immunity.
But vaccines are only one layer. The text highlights a non-biological intervention that is equally critical: reducing indoor air pollution.
We touched on this earlier. Burning biomass fuels like wood, crop waste, or dung in poorly ventilated homes creates a highly toxic environment.
The continuous inhalation of heavy particulate matter and carbon monoxide induces chronic airway inflammation.
It impairs macrophage function in the alveoli, and it literally destroys the mucociliary escalator, those tiny hairs that sweep debris out of the lungs.
The data shows children exposed to this indoor pollution have more than double the risk of developing acute lower respiratory infections.
Which means upgrading a community to clean burning cook stoves is a primary public health intervention against pneumonia.
Now let's look at case management. When prevention fails, and a child in a remote, low-resource setting actually develops pneumonia, how do we diagnose it?
This is where it gets interesting.
I really want to push back on this section of the text. Because if I am a doctor in a modern hospital, I want a stethoscope to auscultate the lungs. I want a pulse oximeter and a chest x-ray to look for consolidations.
Naturally.
But the WHO guidelines for community health workers don't use any of that. They rely almost entirely on visual observation. Isn't that dangerously imprecise?
Well, if you judge it by the standards of a high-resource tertiary care center, yes, it lacks precision. But in a remote setting where an X-ray machine is hundreds of miles away, demanding precision results in total paralysis.
You just can't do anything.
Exactly. So the WHO had to engineer a diagnostic algorithm that could be executed by a community health worker with zero medical equipment, save for a stopwatch.
The stopwatch. So the primary clinical sign used to identify pneumonia requiring oral amoxicillin is simply fast breathing.
The health worker literally just counts the number of breaths the child takes in 1 minute. That is it.
Wow. And how accurate is that?
Fast breathing has an incredibly high sensitivity for detecting pneumonia. It captures roughly 85% of true cases. Its specificity, however, is lower, around 70 to 80%.
Let me challenge that specificity.
Yeah.
That means 20 to 30% of children who trigger the fast breathing threshold don't actually have bacterial pneumonia.
Right. They might just have a viral upper respiratory tract infection or a fever from malaria, both of which increase respiratory rate.
So by protocoling community health workers to hand out amoxicillin based solely on fast breathing, aren't we massively overprescribing antibiotics and accelerating antimicrobial resistance?
You are identifying the central tension in public health policy right there, the trade-off between individual precision and population-level survival. Yes, the algorithm undoubtedly leads to some overprescription of antibiotics.
But the alternative is worse.
Much worse. In a high-mortality environment where bacterial pneumonia can kill a child in 48 hours, maximizing sensitivity is paramount. We accept a minor increase in the rate of antimicrobial resistance because utilizing the fast breathing sign ensures that the vast majority of children who actually have life-threatening pneumonia receive life-saving oral amoxicillin immediately.
It is a calculated, pragmatic survival strategy.
Exactly. And the algorithm scales up for severity, too.
Right. If the health worker observes lower chest wall indrawing, meaning the lower ribs suck inward during inspiration, instead of expanding outward.
Which indicates severe negative interthoracic pressure.
Yeah, that signifies severe pneumonia. And if there's stridor, a harsh vibrating sound on inspiration, or if the child is lethargic, those are danger signs mandating immediate referral to a hospital for parenteral antibiotics and oxygen therapy.
Next on the list of major killers is diarrheal disease.
The textbook outlines a comprehensive 7-point plan for control and treatment. This includes early and exclusive breastfeeding, vitamin A supplementation, rotavirus vaccination, hand washing with soap, improved community sanitation, fluid replacement, and zinc treatment.
Let's dig into the specific mechanisms of a few of these, because just listing them doesn't do justice to the science.
Take the rotavirus vaccine. Rotavirus is the leading global cause of severe dehydrating watery diarrhea in young children.
The virus essentially invades and destroys the mature enterocytes, the absorptive cells lining the tips of the intestinal villi.
And without those cells, the gut cannot absorb water or nutrients, leading to massive osmotic fluid loss.
But the oral live attenuated rotavirus vaccine triggers local IgA immunity in the gut lining, neutralizing the virus before it can attach to the villi.
It is a remarkable preventative tool. But once a child actually has severe watery diarrhea, the cornerstone of case management is fluid replacement.
And the text notes a critical evolution in this area, the shift by WHO and UNICEF to a new low osmolarity oral rehydration salts, or ORS, formulation.
This fascinated me because the ingredients are incredibly simple: salt, sugar, and water. And the original standard ORS was highly effective at preventing death from dehydration. So why did public health officials mess with a winning formula?
Because while the original formulation saved lives, it had a major practical flaw. It did not reduce the volume or duration of the diarrhea.
Oh, so the child's stool output remained high.
Exactly. And from a behavioral perspective, if a mother gives her child a medicine and the most distressing symptom, the watery diarrhea, persists unabated, she loses faith in the treatment.
So she stops using it and turns to harmful traditional remedies or unnecessary antibiotics.
Precisely. So they needed a formula that not only hydrated the child, but actively slowed the fluid loss. To understand how they achieved this, we have to look at the sodium glucose cotransporter protein, or SGLT1, located in the intestinal lining.
This transporter acts as a molecular pump. For every molecule of glucose it actively pulls from the gut into the bloodstream, it simultaneously pulls one ion of sodium.
And where sodium goes, water follows passively via osmosis.
So what was wrong with the old formula?
The original ORS had a relatively high concentration of solutes. If a solution is hypertonic in the gut, osmotic pressure can actually pull water out of the blood plasma and into the intestinal lumen,
Paradoxically exacerbating the diarrhea.
Exactly. So the new low osmolarity ORS was precisely engineered to optimize the SGLT1 transporter without creating an osmotic penalty.
It contains exactly 75 milliequivalents of sodium and 75 millimoles of glucose per liter, resulting in a total osmolarity of 245 millimoles per liter.
That exact 1-to-1 molecular ratio maximizes the active transport of sodium and water into the bloodstream, while the lower overall osmolarity ensures no water is pulled back into the gut.
Clinically, this new formulation significantly reduces stool output, reduces the incidence of vomiting, and drastically reduces the need for expensive, invasive intravenous fluid therapy.
It is molecular engineering delivered in a 10-cent packet of powder.
It really is. Now, the treatment protocol also mandates the inclusion of zinc. Why zinc?
Well, zinc is an essential trace element that serves as a vital cofactor for hundreds of metalloenzymes, particularly those involved in cellular proliferation and immune function.
And during a severe diarrheal episode, the mucosal lining of the gut is heavily damaged, right?
Yes, and zinc stores are rapidly depleted. Administering 10 to 20 milligrams of zinc per day for 10 to 14 days actively accelerates the regeneration of the intestinal epithelium and boosts local mucosal immunity.
So not only does it shorten the duration of the current diarrheal episode, but it actively protects against future episodes for several months.
Notice what is almost entirely absent from the watery diarrhea treatment protocol, though.
Antibiotics.
Exactly. If you are a clinician, the urge to prescribe an antimicrobial when faced with an infection is very strong.
But for standard watery diarrhea, which is overwhelmingly viral, like rotavirus, or secretory, like cholera or ETEC, antibiotics offer no benefit and heavily drive antimicrobial resistance.
Right. The only clinical indications for antibiotics in the management of childhood diarrhea are severe cholera, where macrolides can reduce the duration of bacterial shedding, and dysentery.
And dysentery is defined clinically as the presence of visible blood in the stool. It is most commonly caused by invasive Shigella bacteria, which destroy the colonic mucosa.
And due to widespread aggressive resistance to older, cheaper drugs like ampicillin or cotrimoxazole, the current drug of choice for Shigella dysentery is often a fluoroquinolone, like ciprofloxacin.
Transitioning to the next major pathogen, we look at malaria. The public health framework for malaria is very linear. Vector control, outcome management, and treatment.
So if the house is in a neighborhood infested with termites, the first step is putting up physical barriers.
Vector control is primarily achieved through insecticide-treated nets, or ITNs. Anopheles mosquitoes, which transmit the Plasmodium falciparum parasite, typically bite at night.
So sleeping under an ITN provides a physical barrier, and the insecticide actively kills the vector, reducing the overall mosquito population in the community.
But if the vector breaches the defenses, outcome management requires prompt parasitological confirmation. Historically, health workers in endemic areas were taught to treat every unexplained fever in a child as malaria.
But treating blindly has disastrous systemic consequences.
Right. It means you are missing the children who actually have bacterial pneumonia or typhoid, leaving them to die.
While simultaneously exposing the malaria parasite to a constant low-level barrage of anti-malarial drugs, perfectly selecting for drug-resistant strains.
Therefore, modern protocols mandate confirmation via microscopy or rapid diagnostic tests, RDTs, before initiating treatment.
And for treatment of uncomplicated Plasmodium falciparum malaria, the global standard has shifted entirely to artemisinin-based combination therapies, or ACTs.
Explain the pharmacology behind combination therapy. Why not just use artemisinin by itself?
Well, artemisinin derivatives are incredibly fast-acting. They rapidly clear the bulk of the parasite biomass from the blood, however, they have a very short half-life.
So if used as a monotherapy, some parasites survive and resistance rapidly develops.
Precisely. By combining the artemisinin with a longer-acting partner drug, like lumefantrine or imodiaquine, the artemisinin acts as the rapid strike force, knocking down the parasite numbers.
While the longer-acting drug serves as the mop-up crew, eliminating the remaining parasites and protecting the artemisinin from the development of resistance.
This brings us to a highly complex section of the chapter, HIV and AIDS in children. There are profound diagnostic and ethical nuances here. Let's start with diagnosis.
If you are treating an infant born to an HIV-positive mother, standard HIV testing protocols are completely ineffective. The text explicitly states you do not use an ELISA test for an infant under 18 months of age.
To understand why, you have to look at maternal-fetal immunology. The standard ELISA test does not look for the HIV virus itself. It looks for the patient's antibodies against the virus.
And during the third trimester of pregnancy, the mother actively transfers her own IgG antibodies across the placenta to the fetus to provide passive immunity for the first few months of life.
So, if the mother is HIV positive, her immune system has generated HIV antibodies. Those antibodies cross the placenta and enter the fetal bloodstream, regardless of whether the actual virus crossed the placenta.
Okay, so if you perform an ELISA on a 2-month-old infant, it will almost certainly return a positive result because it is detecting the maternal antibodies, which act like a lingering immunological footprint.
Exactly. Those maternal antibodies can remain in the infant's circulation for up to 18 months. Therefore, a positive ELISA in an infant is entirely non-diagnostic of actual infection.
To determine if the infant is truly infected, you have to look for the intruder itself, not just the maternal alarm bells.
Yeah.
You must use a virological test, specifically a DNA PCR polymerase chain reaction.
Right. The PCR test extracts cellular material and amplifies any integrated proviral HIV DNA. It confirms the actual presence of the virus in the infant's cells.
The next major issue is prevention of mother-to-child transmission, specifically surrounding breastfeeding. This presents one of the most challenging public health paradoxes in existence. We know definitively that HIV can be transmitted from mother to infant through breast milk.
Yes, and if you approach this with a narrow single disease focus, the conclusion seems obvious. An HIV-positive mother should be strictly forbidden from breastfeeding. End of story.
But the WHO guidelines are vastly more nuanced, and they require ultimate systems-level thinking.
You cannot dictate public health policy in a vacuum. You must evaluate the structural hazards of the patient's specific environment.
So let's say in a high-income setting like Toronto or London, where a mother has continuous access to clean, piped municipal water, perfect sanitation, and a reliable, affordable supply of infant formula, the recommendation is absolute. Do not breastfeed.
Right, because the risk of HIV transmission outweighs any nutritional benefit since safe alternatives exist.
But transport that same clinical scenario to a rural village or an informal urban settlement in a low-income country. There is no municipal plumbing. The local water source is contaminated with enteric pathogens.
And the family lives in extreme poverty, meaning they cannot afford a consistent supply of commercial formula.
If they try to formula feed, they will likely over-dilute the powder to make it last longer, starving the infant, and they will mix it with contaminated water.
In that environment, if you forbid breastfeeding, you deprive the infant of the maternal mucosal antibodies we discussed earlier, while simultaneously force-feeding them waterborne pathogens.
The statistical risk of that infant dying from severe dehydrating diarrhea or pneumonia within the first 6 months of life is astronomically higher than the risk of them contracting HIV.
It is a brutal calculation.
It really is. However, modern medicine provides a bridge here, doesn't it?
It does. If both the mother and the infant are receiving highly active antiretroviral therapy, or ARVs, the viral load in the breast milk is suppressed to virtually undetectable levels,
Dropping the transmission risk to less than 2%.
Therefore, in high mortality, low resource settings, the WHO strictly recommends exclusive breastfeeding for the first 6 months while adhering to ARV therapy.
It is the strategy that guarantees the highest probability of overall HIV-free survival.
Exactly. The final clinical condition we need to unpack is malnutrition, specifically the treatment of severe acute malnutrition, or SAM.
Right. If a child's structural integrity has completely collapsed, how do we engineer a recovery?
The first step is identification. The clinical metrics for SAM are a mid-upper arm circumference, or MUAC, of less than 115 millimeters, or a weight for height below -3 standard deviations, or the presence of bilateral pitting edema.
That's the swelling caused by severe protein deficiency, altering the oncotic pressure in the blood vessels.
Yes, and once SAM is identified, the clinician faces a critical triage decision point. Complicated versus uncomplicated SAM. You don't just admit every starving child to the hospital.
The primary diagnostic tool for this triage is the appetite test.
You offer the child a small amount of therapeutic food. If the child willingly consumes it and they lack severe medical complications like pneumonia, sepsis, or profound shock, they have uncomplicated SAM.
The metabolic drive is still sufficiently intact and they can be managed as an outpatient.
But if they refuse to eat, or if they have severe concurrent illness, their metabolic system is in a state of critical collapse. They have complicated SAM and require immediate inpatient admission.
Now, if you are wondering why we don't just give these starving inpatient children a massive influx of calories and protein right away, you have to understand the pathophysiology of reductive adaptation.
All right. The child's body has systematically shut down non-essential functions to preserve energy for the brain and heart. Cellular sodium pumps have slowed down, meaning sodium accumulates inside the cells while potassium leaks out.
The entire electrolyte balance is hanging by a thread.
If you rapidly introduce high volumes of carbohydrates and proteins to that fragile system, you trigger refeeding syndrome.
The sudden spike in glucose triggers a massive release of insulin. Insulin violently drives phosphate, potassium, and magnesium out of the blood and back into the cells to metabolize the new food.
This rapid electrolyte shift causes lethal hypophosphatemia, triggering cardiac arrhythmias, respiratory failure, and death.
It's like trying to surge 220 volts of electricity through a dilapidated 110-volt wiring system. The whole house burns down.
To prevent this, inpatient treatment utilizes a strict two-phase protocol. The first is the stabilization phase. We use a specially engineered formula called F75.
It is intentionally low in protein, low in sodium, and low in overall energy, just 75 kilocalories per 100 milliliters.
Because the goal here is not weight gain. The goal is simply to restore cellular electrolyte balance, clear insidious infections, and stabilize organ function without overwhelming the weakened heart and kidneys.
Once the child's appetite returns and their edema begins to resolve, indicating the metabolic machinery is coming back online, they transition to the rehabilitation phase.
Here we introduce F100 formula, which has significantly higher energy and protein content designed to drive rapid tissue synthesis and weight gain.
For the outpatients who passed the appetite test, the treatment landscape was revolutionized by the invention of ready-to-use therapeutic foods, or RUTFs.
RUTFs are essentially the F100 formula, but engineered as a lipid-based paste, often utilizing a peanut butter matrix.
Fortified with skim milk powder, vital electrolytes, and micronutrients. And the real brilliance of RUTFs is that they contain absolutely no free water.
Because they lack water, bacteria cannot proliferate within the paste. It requires no refrigeration, has a massive shelf life, and crucially, the mother does not need to mix it with potentially contaminated local water.
The child simply consumes the paste directly from the packet. It allows millions of children with severe acute malnutrition to be treated effectively and safely in their own communities, bypassing the need for scarce hospital beds entirely.
We have spent a considerable amount of time outlining the clinical architecture, but public health is fundamentally about the systems that deliver these interventions.
A warehouse fully stocked with RUTFs, amoxicillin, and rotavirus vaccines is entirely useless if the supply chain is broken or if the local population cannot afford to access the clinic.
Section 4 of the chapter pivots from clinical medicine to strengthening child health services.
This utilizes the health system building blocks framework. We have to look at the structural girders of the health system itself: governance, workforce, supply chains, and financing.
Let's focus on financing. In many low-income countries, healthcare operates on an out-of-pocket payment model. A mother carries her child with severe pneumonia to a clinic, and she must hand over physical cash before the nurse will dispense the amoxicillin.
Out-of-pocket systems act as a massive structural hazard that explicitly penalizes the poor. It forces families into catastrophic health expenditure.
They must choose between letting their child die or selling their agricultural assets, like their livestock, their seed grain, to pay the clinic fees.
Which plunges the family into irreversible generational poverty.
So the public health mandate is to transition these nations toward prepayment systems, such as tax-based universal health care or broad social health insurance pools.
By pooling the financial risk across the entire healthy population, you provide financial risk protection, ensuring that a medical emergency does not equate to financial ruin.
The other critical building block is the health workforce. The textbook notes a stark minimum threshold required to deliver even the most basic, essential maternal and child health interventions.
A density of 23 healthcare workers, specifically doctors, nurses, and midwives, per 10,000 population.
Think about that ratio: 23 clinical staff for a town of 10,000 people.
And the text highlights that as recently as 2010, only 5 low-income economies globally met even this minimal threshold. You have massive populations with virtually no formally trained doctors.
When a system faces a deficit that severe, it must adapt its architecture. The primary structural adaptation is task shifting or task delegation.
You take a highly specific, protocol-driven medical task and shift the responsibility for executing it down the educational pyramid to a more abundant, less specialized cadre of workers.
This is exactly what we discussed with the pneumonia algorithm. You do not have enough physicians to auscultate lungs and read chest x-rays, so you shift the diagnostic task.
You train a massive cohort of community health workers to use a stopwatch, count the respiratory rate, and autonomously dispense oral amoxicillin. You task shift neonatal resuscitation to rural midwives.
You democratize life-saving interventions to ensure maximum population coverage.
And to make that task-shifted workforce efficient, public health strategies shifted away from isolated vertical disease programs.
Historically, a Ministry of Health might have a standalone malaria program, a separate diarrheal disease program, and a separate nutrition program.
But an impoverished child rarely presents with just one pathology. A child with a malarial fever is very likely also stunted and may have concurrent environmental enteropathy.
If the community health worker only treats the malaria and ignores the stunting, the child remains fundamentally vulnerable. To solve this, the WHO developed the IMCI strategy, the Integrated Management of Childhood Illness.
IMCI is a holistic algorithmic approach. When a child presents to a primary care facility, the health worker uses a standardized flowchart to assess the whole child.
They check for danger signs, assess for pneumonia, test for malaria, evaluate the duration of diarrhea, measure the mid-upper arm circumference for malnutrition, and check vaccination status, all in one visit.
It minimizes missed opportunities for care and is vastly more cost-effective than running parallel vertical programs.
It is the difference between taking your car to a mechanic just to fix a flat tire versus a mechanic who fixes the tire, checks the oil, tests the brakes, and replaces a dead headlight before returning the car to you. It reinforces the continuum of care.
In our final section, we zoom out to the macro level: international efforts in child rights. The textbook discusses the massive global accountability frameworks that attempt to coordinate and finance all of these interventions.
Historically, this was driven by the Millennium Development Goals, specifically MDG-4, which set a firm target to reduce the global under-5 mortality rate by 2/3 between 1990 and 2015.
This was later succeeded by the Sustainable Development Goals and initiatives like the Global Strategy for Women's and Children's Health.
These frameworks are vital for mobilizing resources, but the text closes by transitioning from public health targets to actual legal obligations, highlighting the UN Convention on the Rights of the Child, or the CRC.
Specifically, Article 24 of the CRC. It states that children have an inherent right to the enjoyment of the highest attainable standard of health. The phrasing here is not merely semantic. It represents a profound paradigm shift.
It shifts the provision of child health care away from being viewed as an act of charitable benevolence provided by a generous government or a well-funded NGO.
Exactly. It establishes health as a fundamental, legally binding entitlement of the child. It elevates public health goals from political aspirations into legal and human rights obligations.
We have covered an immense amount of ground in this deep dive.
We traced the architectural blueprints from the epidemiological transition and the insidious cascade of morbidity through the granular pathophysiology of low osmolarity ORS and refeeding syndrome, all the way out to the macroeconomic girders of health system financing and international law. As we conclude, we want to leave you with a final, overarching thought to consider.
If we accept the premise that the physiological and nutritional exposures during the earliest days of life permanently wire human neuroplasticity, dictate maximum cognitive potential, and lay the foundation for lifelong immune and metabolic responses, then public health interventions are not merely about preventing a death today. They are literally engineering the biological and cognitive capital of humanity's future.
The question to consider in your own practice or study is this: how might our global approach change if we viewed public health funding not as a recurrent expenditure or a charitable drain on a national budget, but as the ultimate macroeconomic infrastructure investment? If a nation desires a robust, innovative economy 30 years from now, building highways and power grids is insufficient. You must first meticulously engineer the brains and bodies of the population who will build and drive on them.
It is the ultimate foundation.
All right, to lock in the critical concepts we have discussed, it is time for our learning reinforcement. I'm going to read 6 rapid single best answer prompts. I will read the question and the 4 options. I'll give you a moment so you can select your answer and then provide the correct answer along with the specific section of the textbook to revisit if you need consolidation. Ready? Here we go. Prompt 1. Which indicator specifically measures chronic nutritional deprivation over a lengthy period of time? Options: wasting, underweight, stunting, edema. Take a second to think. The answer is stunting, defined as -2 standard deviations from the median height for age. Revisit the section on nutrition, growth, and development. Prompt 2. What is the primary clinical sign used in community case management to identify a child requiring oral amoxicillin for pneumonia? Options: central cyanosis, stridor, chest wall indrawing, fast breathing. Lock in your answer. The answer is fast breathing. Revisit the section on acute respiratory infections. Prompt 3. Why are infants under 18 months of age tested for HIV using a DNA PCR test rather than a standard ELISA? Options: PCR is cheaper. ELISA detects maternal antibodies. Infants don't produce antibodies. PCR detects RNA. Think about the immunology. The answer is ELISA detects maternal IgG antibodies that cross the placenta during pregnancy. Revisit the section on HIV and AIDS. Prompt 4. In a low-income area with high infectious disease mortality and poor sanitation, what is the WHO feeding recommendation for an HIV-infected mother? Options: formula only, mixed feeding, exclusive breastfeeding with ARVs, early weaning at 3 months. I'll give you a moment. The answer is exclusive breastfeeding for 6 months while adhering to ARV therapy. Revisit the section on HIV and AIDS. Prompt 5. What is the minimum threshold of healthcare workers, specifically doctors, nurses, and midwives, per 10,000 population required to deliver essential maternal and child health services? Options: 10, 23, 45, 60. Have your guess ready? The answer is 23. Revisit the section on critical subsystems. Prompt 6. Which type of formula is utilized in the initial stabilization phase for a child hospitalized with complicated severe acute malnutrition to prevent refeeding syndrome? Options: F100, RUTF, F75, ORS. Final question. Take a moment. The answer is F75, the specially formulated low-protein, low-energy formula. Revisit the section on malnutrition. If the foundation is compromised by poor weather or substandard materials, the entire lifelong building is structurally weakened. Public health is the engineering that protects that build. Thank you for joining us on this deep dive. Here are the details of this episode.
Child health, byline. Medlock Holmes examines child health across the life course, from survival to development, exploring prevention, system strengthening, and the structural determinants shaping early life. Child health remains a defining indicator of public health performance. While global child mortality has declined significantly in recent decades, preventable deaths from infectious disease, malnutrition, neonatal conditions, and inadequate healthcare access persist in many regions. This chapter explores under 5 mortality, neonatal survival, vaccination, acute respiratory infections, diarrheal disease, malaria, HIV exposure, nutrition, and developmental health. It also examines health system strengthening, governance, and integrated child health strategies. Childhood is framed not only as a vulnerable period, but as a foundational stage in the life course. Early exposures shape lifelong trajectories of health, cognition, and social participation. Public health investment in children yields generational dividends biologically, socially, and economically. Key takeaways. Under 5 mortality remains a critical global health indicator. The neonatal conditions, infections, and malnutrition are leading contributors to child mortality. Vaccination and integrated child health programs significantly reduce preventable deaths. Early nutrition and development influence long-term life course health. Health system strengthening is essential to sustaining child health gains. Child rights and equity are central to population health improvement. Investments in early life produce long-term societal benefits.